Greetings, Dr. Mark Winton here from University of Central Florida, and the goal of this short video is to introduce you to the concept and the practice of risk assessment. If you think about it, the whole idea of defining risk has many problems, primarily the subjective nature of what we consider to be risk, and also the problem with labeling someone at risk. And that obviously we're going to have false positives, false negatives, and that certainly can be problematic. But we have some research that shows what specific combination of factors increase the probability that someone will engage in specific behavior, whether that be domestic violence, sexual abuse, drug use, or other criminal activities. Hannah Moffett in 2005 published an article, Criminogenic Needs and the Transformative Risk Subject, in the journal Punishment and Society, pages 29 to 51 in volume 7, and pointed out some important factors related to risk assessment, and then also traced the changes in the patterns of risk assessment. For example, risk assessment has shifted from static factors to dynamic, changeable type factors. Hannah Moffett asks, how do we calculate, classify, construct, and determine risk? And as I mentioned, that there's some problems with that. The other thing I wanted to mention is that there are literally hundreds of risk assessments out there for a variety of violent behaviors, violent activities, violent thoughts, history of violence. And one of the features, of course, is what do you choose? And my recommendation is choose what you find in the research that would be appropriate for the individual or the population that you're working with, and read up on the research on that assessment tool to make sure it's reliable and valid, and that it's been field tested, and that you can interpret it easily. And so, and also, that you're able to have a purpose to use that for whatever reason that might be. But the situation with risk assessment is that it can lead to what Hannah Moffett describes as the new politics of punishment, and also with the competition of scarce resources, that those that are at higher risk should probably receive services quicker and more intensely than those at lower risk. And also, this may lead to a redistribution of responsibilities. Who's responsible for carrying out risk assessments and for implementing whatever policies or interventions would come from that? But I think looking at the changes over time would be relevant. And so there's really 4 generations of risk assessment tools that Hannah Moffett points out. The first generation of risk assessments really was more subjective, where the one doing the assessment, usually a mental health clinician or a psychiatrist, would, based on their experience and knowledge, make a subjective assessment of risk. The second generation of risk assessments use statistical prediction using static variables. For example, that we know that young men are more likely to commit violence than elderly women. And so there you have being young, age factor, and being male as 2 potential risk factors. Being elderly and being female, 2 that would lower risk of engaging in violence. The third generation, of course, static variables sometimes become problematic as well. What do you do with that? And so that's why we move toward the dynamic or changeable ones. The third generation risk assessments focused on measuring static and dynamic risk factors. And those dynamic risk factors in the assessment tools were criminogenic need factors. And then the fourth generation risk assessments, which we kind of see being used now and probably more so in the future, is identification and measurement of key responsivity characteristics for treatment. In other words, we want to know that we conduct a risk assessment. We want to know specifically what do we need to do to reduce that risk. And so Hannah Moffett points out that this has led to a four-factor approach. One, that risk that when we look at risk and we look at need, we look at responsivity, and also professional discretion. So you get this R&R model that you may have read about before, that looking at risk, we predict and match treatment to risk level. We also look at needs, or the targeting of criminogenic needs with the appropriate treatment. And then also the treatment is specific to the offender. That we would expect the offender to respond differently to different treatments. So we want to go ahead and present and implement the treatment that's most likely to get the best response. And then also professional discretion, that there is room in this model for professional judgment. And so we see that situation occurring. And trying to put all this together kind of in a risk assessment idea, I'll just pull this book out of my bookshelf, Violence and Mental Disorder, Developments in Risk Assessment, edited by John Monahan and Henry J. Stedman. This was published a long time ago, 1994, published by Chicago Press. I actually used this book in one of the first violent crime, violent criminal courses I taught. And it's still, I consider this to be a classic. And on page 303, and throughout the book, even if you look in the table of contents, you see that they talk about risk assessment research and different domains. Now, they base it on the MacArthur Risk Assessment Study, and I'm not going to get into that. There's literally hundreds of articles looking at what risk factors are present for those with different mental disorders. But they looked at basically four major areas. They looked at dispositional factors, and those would be demographic factors such as age and gender, and personality styles, how anger or impulsive one might be, and also cognitive abilities such as IQ, or whether or not the person had some type of neurological issue. And so those are the dispositional factors, kind of predisposing, if you will, to certain behaviors. The second area are the historical factors, and that's the social history, the person's upbringing, their family dynamics, their employment history, their education history, and also their history of hospitalizations for mental disorders, for example, and also for crimes and previous violence. And then the third area are the contextual factors, such as the perceptions of stress and the social support systems that are available. And also if they have, and I think this is a real important one, the means for violence. And Monahan, Stedman, and colleagues point out guns as an example. And then the fourth area are the clinical factors, and that relates basically more to diagnosable mental disorders. Now, this was put together way before the DSM-5 came out, but you'd use the Diagnostic and Statistical Manual, Mental Disorders, the 5th edition, the most recent one. And so you kind of put that all together in trying to assess risk. When I started to put together this presentation, I thought, well, I would just present some risk assessment tools, and I mean, I literally have stacks and stacks. I've been doing this for about 30 years, and I collect all kinds of assessment tools throughout my career, and one of the problems is that I have I'm unable for some reason to throw away the older ones. Even the new editions I keep, but I like to keep the old editions and see what has been revised. And I consider myself a collector of assessment tools. And fortunately, a lot of the assessment tools are online now. And so I really could clear out some of my files. But I'm always thinking about what would be the best assessment tool to use in a particular situation. And I actually have conducted some assessments before when I worked as a counselor, and I'd usually use about maybe 3 to 5 different tools depending on the situation. If someone was at risk for depression or depressed, I'd use a depression scale, for example, the Beck depression inventory. If I was seeing a parent that was under a great deal of stress, I might use the parenting stress index. A lot of these are protected for the mental health professionals to use, and you have to be licensed in order to obtain them. But then there's a lot of other assessment tools that anyone can use. And for example, the CDC, Centers for Disease Control, has a whole bunch of assessment tools focusing on domestic violence and youth violence and juvenile delinquency. And so you're able to review those if you want. And then a lot of people create their own assessment tools and use them. Later on in the semester, I'll talk about violentization theory, and that's basically how I approach risk assessment for violence. And I'll talk about the tools that I use when I conduct research there. And depending on the situation, there's other assessments that you can get into, and I've always found it extremely fascinating. In fact, I found when I first started out in the field back in the 80s, and I took a course on testing and measurements. I started doing internships at mental health facilities. So I took a lot of those assessments myself and scored them myself, and then either interpreted them myself or asked one of the mental health professionals to. I remember I took the MMPI, and I brought it in to one of the staff clinical psychologists, and I said, "Can you interpret this MMPI?" And she thought it was for a client. I didn't tell her it was mine because I wanted to get a more objective view. And she looked at it and she said, "My gosh, your client is just one boring individual. Tell them to get a life." I said, "Well, thank you." Now, of course, I was working and going to graduate school and doing an internship, so that would be normal not to have a life outside of those three domains. But there's a lot of different assessment tools out there. I'm unable to become a member of Mensa because I've actually reviewed and studied the IQ tests and was used in training as so I was administered the test frequently over a period of time to help train other clinicians. And so eventually it's kind of like studying for that. So I'm can't do that, right? Because I would score, maybe as a genius, but that wouldn't be a valid or reliable. Well, it'd be reliable because I keep scoring as a genius, but it wouldn't be valid, right? Because I know how the test works. And wow, did my intelligence improve rapidly over a short period of time. But I would say it is somewhat stressful when you have 25 people watching. Okay, so back to risk assessment. I think the important feature here that we run into is the ethical dilemmas that we face, and of course the liability issues. That if you're in law enforcement or child protection services or corrections or many of the fields that we're in, that we have to make decisions what to do about a situation. For example, we may have to decide, well, do we have this person hospitalized or not? Are they a risk to themselves or others? And we make a judgment call. And we want to base that on some data that we have, maybe statements from the person, statements from the person's family, statements from other witnesses, past behaviors, current situation. And it's a tough situation, because you certainly don't want to unnecessarily hospitalize someone on the one hand, but you also don't want to fail to hospitalize someone and then they commit a horrific crime, or they commit suicide or something of that sort. And to me, it always seems like the public thinks I'm Kreskin, that I can read minds and I know exactly what's going to happen next. And if I was to evaluate someone and then they did something that I should have known better. It's kind of a double-edged sword too. And if you think about it. And I've seen that in various places where I've worked before, and that's just part of the reality. And that's why I think it's real important to use reliable and valid assessment tools and to collect as much data as possible. One of the reasons I got out of the counseling field is I was working in the era of managed care, and I took too long to do my assessments. And I got very frustrated because by the time it got around to interventions, I'd already used up half of the allotted sessions. So I'm just much slower in conducting assessments, for better or for worse. I try to be very thorough, as you can guess. So I also wonder about free will. Does that come into play at all? In other words, the person having control of what they're doing. And how does that relate to our assessment? And so obviously if someone is psychotic or is actively under the influence of drugs or alcohol or some toxic substance that's creating a lot of variation in their thought patterns, that's very different than someone who's deciding to do something based on their own free will to determine whether or not they wanted to do that. There's a lot of debate about all this. There's an interesting case study that my colleague and I have talked about before, about this individual who was doing fine and then started acting out sexually inappropriately, and went ahead and was referred to medical workup. They found a brain tumor. They treated it. Went back to normal behavior. And then a couple years later, he started acting out again. They found the brain tumor had grown back. They treated it, and then he didn't act out anymore. And so, with that situation, how does free will and ethics and the criminal justice system and play into that? So we have a lot of different issues here. And I think that we can cover some other factors later on in other videos. I don't want to try to do too much, but focus more on just kind of the basic concepts and ideas and some of the trials and tribulations related to conducting different risk assessments. Thank you.